Good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec Adair. I'm the Managing Director for Wound Care People. Tonight's session is Offloading the Foot in Diabetes. And I'm very pleased to be joined by our two speakers this evening, the wonderful Joanne Casey, who's a Podiatry Project Officer at the Royal College of Podiatry, and Jill Sykes, who's an Advanced Podiatrist at Harrogate and District NHS Foundation Trust. Joanne and Jill, how are you?
Great, thank you. Raring to go.
Good.
Very good.
I know this is your first event, and I know that you are very, very excited to be with us. And this is a very important week. This is a very important event. Sorry, this is supported by Legs Matter, which is an organisation which you'll hear a bit more about during the presentation. But it's a fantastic organisation with some fantastic members, and we're very pleased to be working with them. So thank you to all of the team at Legs Matter for putting on this event with us. For those of you who are joining us for the first time, just to let you know, certificates will be available at the end. There'll be a link provided by one of my colleagues. You'll see that we are all presenting in our own homes. So if there's any technical issues, just do bear with us. We will come back to you as soon as we can. And as always, we couldn't do these events without the audience participation, because at the end of the presentation, there will be a live Q&A. So please do ask as many questions as you possibly can through the chat section, which is depending on which device you're using. You can press open to see the comments. Engage with your colleagues, please. There's going to be people watching from around the country. We'd love to know where you're watching from. This is, as I said, a really important event for us. So we'd love to know where you're watching from and what type of job you're doing and why you're watching it this evening. When we do read every comment, I'm going to shut up now. I think that's probably me done. So I'm going to hand you over to Joanne. I'll be back after the presentation to host the live Q&A. It just leaves me to say again, thank you to Legs Matter. Thank you all for giving up your precious time on this windy in Cardiff Tuesday evening. And Joanne, Jill, good luck. And over to you, Joanne, and I shall see you both very shortly.
Thanks, Alec. That's great. Jill and I feel really privileged actually to be part of this tonight, because we're really keen to get the message across on the importance of offloading the foot in diabetes. Offloading and the foot are a bit of a Cinderella sort of subject, really, in the sense that they're a bit underrated. People don't really tend to consider maybe what we're wearing on our feet or the importance of feet in mobility and how important it is to maintain our mobility throughout our life. So we've just got a couple of learning objectives from today's slides, and we'd really like to raise awareness with you of the complications associated with the foot in diabetes, to highlight the importance of foot assessment in the patient management to prevent or manage foot ulcers, and to develop an understanding of the importance of offloading and the devices that might be used in the prevention and treatment of foot ulcers. So what we really want to do at the beginning, and that's my job this evening, is to set the scene for you. What is it about diabetes? What is it about the foot that makes it so important? And also how do we, and then Jill will then talk about offloading the foot with all the devices that we use to maintain good foot health. So the impact of diabetes then, so if I set the scene a little bit for you, diabetes is having a seismic effect on the population of the world. I cannot tell you how it is trajectorying beyond control at the moment. And the charity Diabetes UK states that currently in the UK, this is obviously a slightly older data, but 4.7 million people are diagnosed with diabetes. That's 1 in 15 of us. In this room tonight supporting this particular seminar, we've got about 5 of us. So if we had just 5 more, that would be at least 1 of us in this room would actually have diabetes. So when we then think about the size of the amount of people with diabetes in England, that's 3.2 million people. And then if you consider London, London has 9.8 million people in it, roughly. And so that would be a third of London. So the third of population within the M25 would have diabetes. If we were to consider everybody in England being popped into within that M25 section. So that's one big human health traffic jam. So how does the NHS proportion its funding for this? Well, the NHS's spend is 10 billion per year on diabetes, which is 10% of the NHS budget. That's £315 per second. I know that I've been chatting now for several seconds. I won't do the math on that, but that's definitely now we're going to be into thousands of pounds. And by the end of this presentation, I dare think tens of thousands probably. So if we're then looking at the estimation of diabetes, and actually we're thinking we're going to be hitting 5.5 million by 2025. So we're going to need a lot more than just a pot of gold at the end of the rainbow to balance these books. The World Health Organization has also ranked diabetes as number 9 in all global diseases for diseases leading to death. And with a foot ulcer being the primary, well, being a high risk factor when we consider mortality in those patients living with diabetes, you can see how this is now a matter of urgency to think about prevention. So we're thinking about prevention of diabetes, and then we need to think about prevention of foot ulcers. And that's hopefully what we're going to try and get over to you today in our conversation. So the National Wound Care Audit, that is a continuous audit of diabetic foot disease in England and Wales. And the audit enables all diabetes foot care episodes. So it collects all the episodes of foot ulcers that are recorded. It is as good as those that record it, admittedly, but still it's now become compulsory pretty much in every area to actually deliver this data. So this data gets then centralized, and then the findings are put together. And back in May 2019, the number of ulcer episodes submitted to the audit increased by 57% from the previous audit. So you can see probably that would be an increase in people reporting it because as with anything, it takes a while for audits to sort of filter in, but also the amount of ulcer episodes happening, because we do know there's been an increase. You know, we only need to look at the burden of wound care study from GUESS 2020 to know that wounds are on the up. So we've got 57% increase of new ulcer episodes. So the audit is really great for us to understand how we can deliver services to try and assist people living with diabetes foot ulcer, and to try and prevent that happening, because this cannot continue. These kind of numbers can't keep going up. And the actual ulcer rate, it looks at the 14-day referral period. So what it's looking at is how quickly patients are referred into a service, and then the outcome after that. So have they healed within 12 weeks? And how quickly were they put forward into the service? So, for example, if the patient wasn't put forward in 14 days, we know that the likelihood of that ulcer having healed within 12 weeks is reduced. So the quicker they're referred, the quicker they may get healed. So we then have a little think, that's the impact of diabetes, and then how we can report on the impact of diabetes. So we look at foot assessment. Why do we assess a foot? Assessing the foot will allow us to identify and monitor risk. It allows us to inform the carer, inform the patient, and it will allow us to inform other healthcare professionals at what problems are there early on and how they can try and prevent anything deteriorating. If we're looking at that explosion of numbers from the data, then we have to do a rethink. Where do we start? How do we prevent diabetes foot complications? We are concentrating on one area tonight, and that's offloading the foot. But we hope that this presentation will give you a rounded view to the patient and understanding what it is about the foot in diabetes that will put people at risk of developing foot problems and why they might need to be offloaded. So we assess the foot, and the importance of that information is to help people understand the importance of foot health and to monitor and care for their feet. So that building on that importance then, why is it important? Well, if you don't prevent it, then it may develop, and we know that the foot ulcer may develop, and we also know that foot ulceration leads to a high level of mortality. So how do we go about assessing the foot? Well, the NHS's 10-year plan is about building community resilience, and enabling patients to take ownership of their own health. So again, thinking prevention. So that's why it's important to understand what it is about the foot that we need to identify and how we go about monitoring these changes. And if we don't identify the problems early, then actually the foot might be at risk of infection, wounds, pain and discomfort, and immobility. So identifying problems are key, and the earlier the better. So if we take the foot, so we've spoken about the epidemic, the problem that we have with diabetes, the explosion of the numbers. We've spoken about the ulcer rates and how we're seeing an increase in that. We've understood how we need to assess and identify early, but what is it specifically about the foot? So we need to go back to the anatomy. So if we take any part of the foot, any part of that foot there on the screen, you can see there's intricate bones, muscles, ligaments. The foot comprised of 26 bones, 33 joints, and more than 100 muscles, tendons, and ligaments, each working together. They work completely together. And if they don't work together, then actually there can be a problem. So when we need to think about that in ways of alignment, so we think about it with if any imbalances occur. So we just have, and things like arthritis, for example, might create a problem. If you think about a joint not being able to move, how will that affect your balance? How would you walk? So we need to remember that that foot is a springboard and also a rigid lever for us to manipulate our movement over land. Each of those little tiny joints, from the moment that we're born, from 8 months old, we start to walk, right up until the end of our years. It's the mobility of our feet and lower limbs that keep our mental and physical health strong. So it's really important in maintaining foot care, but we have to think what's under the skin. What sits under the skin that we need to protect to make sure we don't see any deterioration in foot health. Just a couple of foot facts, just to keep this light. The foot is a unique structure, as we can see from the slide before, and it adapts for standing, walking, and running on different terrains. I guess probably I say prehistoric, but sort of in times past, when we were sort of walking the land for hunting and gathering, we would have been barefooted. So we needed that rigid lever, and we needed that bag of bones to manipulate our foot position over rocks, grass, sand, for swimming. And so it's important that we understand how the foot works in all of those terrains to be able to really understand what it needs now in what we see as a much more industrial setting, such as concrete on the floor, hard wooden floors. What do we need to do to protect it? The average adult will walk over 75,000 miles in their lifetime. So that's a monstrous amount. And it's the equivalent of traveling 3.5 times around the world. So if you were to think about that, it exhausts me thinking about how I might do that. How do you walk 3.5 times around the world? Well, actually, it's over a period of time, of course, so it's not all in one shot, but it does mean that we need to think about how we're going to maintain our foot health over that period of time and how we're going to keep the mobility. But it's not just necessarily about the keeping mobile as such, it's actually also thinking about the skin and the tissue health around the mobility. So we've got the foot structure, the anatomy that we know of, but how do we maintain the skin and tissue health? For example, I've spoken a lot here about actually using feet to walk, but in the Legs Matter Foot Health Week that we had, our Foot and Lower Limb Health Week we had back in October, we had a session on Neris. And Neris was a lady in a wheelchair who had lost the use of her legs and feet in a traffic accident. But her limb and foot health is still really important because she can't move her feet. She's still at risk of developing foot ulcers, pressure damage. So she still needs her feet to maintain good health. So we need to understand how we're to offload feet even when we're not using them for mobility. So it's not even just those patients that are mobile, it's those patients that are non-mobile that we actually also need to consider. So how do we do this? In short, a basic way to think of it is a 5-point foot assessment. We think about shape, skin and nails, circulation, sensation, and footwear. So if we think about shape, what does the foot look like? Are there any joint deformities going on there, like a bunion joint? Are there any clawed toes? Does the foot have a rocker bottom, like in Charcot foot? Is the foot in alignment? Is there a previous amputation there? We have a little think about all of that. What does the foot look like? Because we need to think about what we're going to do to protect the foot, to walk over the terrains that we've been talking about. So skin and nails, assessing the whole foot includes looking between the toes, looking at the nails, and considering a previous history of ulceration. Are there any scars that you can see? Are the nails particularly thick? Are they bruised? Is there any bruising on the skin? Is there any fragility in the skin? Are there fissures? Has anything broken down in the past? So we need to think about that as well. Circulation, we need to assess the blood supply to the feet, and we do that by observing the foot. By observing the foot and skin, we can look to see whether or not the skin looks viable. Is the foot warm? I'll go on a little bit to circulation later, but there are things that we can do as well as palpating the pulses. There are further diagnostic tests that we can do to assess circulation. But also remember asking the question, have you had any circulatory problems in your legs or feet before? Have you had a previous bypass? Have you had stenting? And think about medication there too. Are they on any anticoagulants? Are they on aspirin? Is there any reason why the circulation in their feet might actually be impaired? So then looking at sensation. So sensation is looking at our nerves. And how do our nerves work? We've got motor, sensory and autonomic nerves. Again, I'll go into that in a little bit more detail later, but we need to think about whether a patient can actually feel their feet. My example with Neris, she wasn't able to feel her feet. So how do we make sure that she's able to assess her foot properly? Well, she has to use another sensation, and that'll be at sight and touch, checking in a different way. So we need to think about sensation. Do they have feeling to their feet? And then what footwear are they wearing? So are they in a slipper? Is it a sloppy slipper? Is it a sensible slipper? Are they in a trainer? Are they in a high heel? Are they in a shoe or footwear that's appropriate for the work that they're doing? They might need, and I know probably Jill will go into this a bit more, but they might need protective footwear. Is that appropriate to their job? And is it causing any problems? So we need to think about, look at the shoes as well. So you look at the shape of the foot. Does it fit the shoe? We look at the skin. Is there any history of damage? We look at then circulation and sensation. So it's a 5-point assessment. NICE gives us some guidance on this sort of assessment, and it comes about through the foot risk stratification and triage. And what it does is allows us to look at the foot and assess the shape, skin, circulation, sensation, footwear, and whether or not people are able to actually look at their feet. And it puts it into risk category. And we consider the risk category as low, moderate, high, / in remission, and active. So what do we do when we then, once we've done the assessment, we've categorized what color coding they might be in? Well, on the triage section of that form, it does actually show you what you should be doing with your patient. So it gives you the best patient pathway. So for example, we think about our 5-point assessment. They've got no risk factors. They've got a normal shaped looking foot with great range of motion within the joints. There's no skin and nail problems. There's no circulatory problems. There's no neuropathy or sensation issues. They've got good footwear. They're perfectly able to look at their feet. They are living with diabetes, but they've got no risk factors. So they're low risk. And so actually, NICE suggests you can have an annual screen by a trained healthcare worker. You must give education, advice, offer advice on where you can get help if you develop a problem, and also get them to check their feet regularly, because you never know when a problem might occur. If you are moderate risk, you have one risk factor present. For example, loss of sensation, signs of peripheral arterial disease, that's circulation, or you're unable to or have no help to self-care. What they've also included in here is an eGFR of equal to or less than 15. So that means that they've got some kidney function issues, and they're possibly going to be onto that dialysis level. So their glomerular filtration rate is very low. That puts them at moderate risk of developing a foot ulcer. So that then means they need a little bit more care and attention, because they could deteriorate to a foot ulcer. And as we know, foot ulceration can lead to high levels of mortality or immobility, and then poor general well-being. So actually they need to be referred into have a proper foot assessment from a podiatrist or a trained healthcare professional. And we need to really give more advice about footwear, offloading, and maybe seeing people if they've seeing whether or not they need to have further diagnostic tests. High risk foot, that's 2 or more risk factors. And so you can see the difference here between moderate and high. You go up to high risk of developing a foot ulcer with just 1 extra risk factor. So if that risk factor, say you had neuropathy, nerve damage, and then you had a callus. So now you've got a callus on the foot. That's a risk factor because that's not normal on the skin. Calluses come through high levels of pressure. So we've got neuropathy and callus. That puts a high risk of developing a foot ulcer because of the shear under the tissue. So then, of course, if you're at high risk, you need to be referred to a podiatrist or to the diabetic foot team, and then they will do a more thorough review and they will try and offload the foot, for example, in terms of a callus, to make that foot go back into a moderate risk category. So actually they're not as high risk because the callus is gone. So they try and educate, they try and prevent. High risk also sits anybody that's had a previous ulcer. So the active risk, which sits at the top, is an active risk of infection, active risk of ulceration, gangrene, ischemia, red hot swollen foot, presence of with or without pain. That's an active issue. Something's going on in that foot that's causing distress to the foot. Once that would be obviously referred to an MDT very, very quickly. But if they are out of that period, they can come back into the high risk. But if they've had an ulcer, they will remain high risk always because they've had that previous ulcer attached to diabetes foot disease. So we always need to be assessing regularly, and they need to be given offloading device, need to be checked, made sure there's no deterioration and given good education. So really, I guess, thinking about the 5-point foot assessment, which is in short a basic assessment, but then it might help you identify any risk associated, and then that risk can be put into the stratification, and you can be looking then at how best to triage the foot. I said I'd go back into a little bit about vascular disease, because when we think about diabetes foot disease, we think about a few things. Think about peripheral arterial disease, so ischemia, we think about neuropathy, we think about renal disease, and we think about infection. So vascular is a great way to start. So we have the foot, we've done our 5-point assessment. Point number 3 is circulation. And we think about the pulses in the feet. We don't actually need a lot of diagnostic tools to first necessarily assess if the foot has a good vascular supply. We look at the leg, we look at the foot. Is the temperature nice and warm coming down? We expect it to be colder nearer the toes, but is it freezing? Is it freezing from the top? Is the foot blue? Is it not looking like it's viable? Is the skin very brittle? Is there some muscle wastage? Has the patient got any symptoms of arterial disease, such as claudication? If we cannot feel any of the foot pulses, we need to go on to further diagnostics. So that would be maybe using a Doppler ultrasound. It might be using toe pressures. It might be using ankle brachial pressure index, ABPIs. And then we can go on to duplexes and MRA. So what we're trying to do is consider whether the foot is in an ischemic state, because when we're looking at the foot, we need to make sure that it's healthy and viable enough to be able to heal if there's any problem. So a few things that you might notice might be gangrene or necrosis, that's skin death, that's tissue death. Ischemia is restricted blood flow or reduced blood flow. And of course, claudication pain is a pain on walking. So when the patient's moving, if they develop a cramping in their leg, then actually that might be associated with narrowed or blocked arteries. So we then need to think about what we're going to do and how to assess circulation. The other complication is neuropathy. So neuropathy is the leading cause for foot ulceration, and it often goes unnoticed because you don't always tend to know when you stop feeling. It's only when someone says, "Can you feel that?" And you're like, "Oh, no, actually, I can't feel that." And that often will get picked up at the assessments. So every year, the patient living with diabetes is going through the foot assessment. That's in the low risk pathway, that's done by the GP or practice nurse, can be done by a podiatrist, healthcare professional. And they're checking for neuropathy. They use a 10-gram molar filament just to start, and they put it over several areas of the feet, and they assess whether or not they can feel it. And they've got 3 different areas of neuropathy here. That would be associated with sensory neuropathy, which is with pain, pressure, and heat. And we think about autonomic and then motor as well. So motor would be small intrinsic muscles of the feet might be wasted away or leading to deformity, weakness, or paresis. And autonomic would be vasodilation and decreased sweating, leading to dryness or fissuring. I've mentioned other complications, renal impairment and infection. Renal impairment, of course, is becoming more and more predominant now because of the ever-aging population and cardiovascular disease. So it's really important to think about the kidney function of your patients, because that might up their risk factor in that stratification and triage. So the musculoskeletal assessment of the foot, that's really important, and where we're probably leading most of our talk today is thinking a little bit about the physical appearance. We spoke about the 5-point assessment, shape and footwear. So this is where this comes into play. So the shape, assessing the foot for any deformities or any previous trauma, and footwear, assessing the footwear, including size and shape. So we need to do that by thinking about clinical examination. So the clinical examination is sitting, standing, walking and balance. When the patient is just sitting, do they need footwear that would be something more appropriate for walking? If they're standing and walking, what sort of footwear do they need? And is there a difference between indoor and outdoor shoes? So if you're thinking about assessing your patient's footwear, are they wearing great shoes outdoors? And are they wearing good shoes indoors? Now, if we consider COVID, we've all been indoors for a long period of time. And actually, the amount of stories I've heard about people developing plantar fasciitis, developing pain in the feet, that's because we're not wearing, for the majority of the day, the supportive shoe that we should be wearing, considering we now have hard floors, concrete floors. You know, we don't have that soft grass that we used to walk on, you know, back before when I was talking about the adaptation of the feet over different terrains. So we still need to consider supporting our foot in good shoes, maybe a light shoe throughout our day, whether we're indoors or outdoors. So indoor and outdoor shoes are really important to assess. And so why do we assess these things? Well, we assess these things because we need to think about the pressure attached to the foot. Remember all those 33 joints, all those tiny bones? We need to think about how we can protect them and think about the mechanical load, the biomechanics to reduce tissue stress, pressure, shear and friction. So if we think about the mobile foot, how is the mobile foot loading during walking? Are we overloading a certain point and developing a callus? How do we offload that? Or if we think about my example of using Neris, who is in her wheelchair, how do we reduce the load from Neris if she's sat in a wheelchair with metal foot plates, or she's lying on her bed for a while, unable to move her feet? How do we consider that? And I know that Jill will go into this more in her presentation. We also think about load redistribution and load sharing. So we need to think about how we can manipulate the weight or the load through the foot to correspond with the associated structures that are sat back in with that anatomy diagram that we saw. So we look at this in two ways. The first way is preventing a foot ulcer with good footing footwear and education, and that's in the intact or healed foot. And then we also look at it offloading devices in ulcer management. And I know that Jill's going to put that in her presentation, but I just want to show you an example of a pair of feet, which I'm pretty sure we have all seen this type of foot. Now, what shoes did they have? These are questions for you. What shoes did they have to wear indoors and outdoors? What areas of pressure could you imagine being associated with that particular foot shape? Think of the anatomy. Where does the ankle bone sit? Where do you think the shoe collar around the back is going to actually hit the ankle? Is that going to hit the ankle? How do we offload that? If you look at the forefoot, just in the distance there on the right side, you can see the toes look slightly retracted. We've probably got neuropathy, and we've definitely got some clawed toes. So there's pressure probably on those toes too. What shoe would you put in? Would you refer them on? Look at the varicosities in that leg. What do they have any? They've got dry skin around the heels. So we need to think a little bit more about the foot and the shape. So offloading is important, which is what Jill's going to go into, and she's going to show you some devices, but understanding why we offload. Now that's the important bit. And I hope I've been able to explain that in the sort of last few slides. So I'll hand over to Jill now, who's going to complete this presentation. Thanks ever so much, Jill. Thanks.
Thanks, Jill. So we're asking ourselves, why is offloading important? As clinicians, the combination of loss of protective sensation and elevated mechanical stress leads to tissue damage and ulceration, as we've talked about earlier. But once tissue damage or foot ulcers occur, healing is chronically delayed if the area is not effectively offloaded. As podiatrists, our caseload acutely is inundated with chronic foot ulcerations, which can go on for months and months. So the overall principle of offloading is to reduce or remove pressure from the site of the foot by redistributing that pressure evenly across the rest of the foot. So we need a multidisciplinary team. This is my passion. Why refer? If your service can't provide an access to load redistribution device, the patient should be referred to a podiatry-led team. This team has the knowledge and skills of offloading the foot. It's our bread and butter, our daily duty, and our expertise in fully understanding the principles of specific pressure relief and management of the foot. So here we are, we have the patient in the centre of the care. These are pinnacle to what happens further forward with the patient. This also includes the patient's relatives, their carers and their family. More and more during COVID, as we've mentioned, we needed to be involving family and carers in the patient's care. There's a whole raft of disciplines involved. These are to name but a few. But I've highlighted in red podiatry. We're often the person that has to coordinate, communicate, and get people together. It's hard work, it takes time, but it pays off. So we have the orthopaedic and vascular surgeons. They're crucial, obviously, for their ultimate decisions. The physiotherapists are very important in helping the patient keep mobile, keeping their core stability, and preventing falls. The nursing teams that we work alongside, the tissue viability nurses, practice nurses, district nursing teams, a wealth of knowledge that we're always learning from all the time. And not forgetting the diabetologist. I learn every single clinic, every different clinic, a different thing about diabetes and the in-depth knowledge that they have. And not to forget our orthotist, I'll talk about in a little while. But there are other disciplines as well. The occupational therapist that will look at aids to daily living in a patient's home, and also a dietitian, not to forget their crucial work they do in maintaining the patient's general health. So early recognition of a foot at risk and developing skin breakdown is essential. We need to identify any risk factors and prevent skin damage, whether that be underlying factors, intrinsic factors, or external factors such as footwear. Where skin breakdown or risk is evident, think prevention with load distribution devices. It's best as a podiatrist or even as a nurse to do local research, look at our local shops, our footwear shops, find out what's available out there for patients, what's within their price range, what they can afford. We've got two very different pieces of footwear we're looking at now. But there are really good things we need to consider when we're offloading the foot. If we offload the foot well with footwear, this can be the answer to all our problems. So we need to consider length. If we have a swollen foot, an edematous foot, the length of the foot, the size of the shoe will make no difference. That's the anatomical length of the foot. Maybe a little bit of swelling around the toes, but generally it's the circumference of the foot, which allows us to fit the foot properly. So we'll be looking at width, the height of the foot, the height of the shoe with the actual toe box. Is there enough depth in the shoe to accommodate swelling? The material, is it made man-made? Is it going to make the foot sweat? Or is it a good leather that makes the foot breathe? The heel height, obviously, will be overloading the forefoot if we go onto that right shoe, which is actually something I couldn't probably even wear for 10 minutes these days. But also the fastening. We don't want to be holding our foot onto a shoe. We need a fastening like a lace, a buckle, and even an elastic shoelace. That opens up options for people who have got elastic shoelaces that then will provide a laced up shoe like a slip-on shoe. So check the inside of a shoe with your hand. Pop a glove on, anyone can do it, and look inside of a shoe. Is there any rubbing of the inner lining? Is there any creasing? Look at the inner sole of the shoe for excess wear marks. And look at the sole of the shoe for unusual excess wear marks and foreign bodies, such as shards of glass sticking through the sole of the shoe, drawing pins, etc. Also, find out where your nearest shoemaker or cobbler is. I know they're a dying breed, they are a dying breed, and they're exceptional in their skills as well. But they can look at things like stretching a shoe for a patient in a certain specific area, or looking at putting a raise onto one shoe. If you realise that a patient has got a leg length discrepancy, whether it be from a hip fracture or a knee problem, they can be walking differently with a leg length difference. So putting a full raise with a taper to the toe box on a shoe can solve problems immediately. This is what you can check from inside a shoe. If you look at the excessive wear marks here, the patient is really overloading right through the heel, onto that lateral side of the foot, the outside of the foot, and then toeing off with the big toe. Far too much pressure. That is not even distribution as we would like. Joe mentioned sloppy slippers. Now, this is an example of real sloppy slippers. This poor lady had leg ulceration, foot ulceration, and compression stockings, as you can see. She was extremely overpronated on that left foot. The right foot, as you can see, is fairly straight and in alignment. She couldn't bend down to do any fastenings, didn't have a long-handled shoehorn, so she just pushed her feet into these sloppy slippers. Alarm bells ringing, massive falls risk here, and we've got to think about educating these patients to having more supportive slippers with better material, even an indoor shoe. A shoe, like Joe was saying, where patients are semi-housebound, they're not really going out much. Why not wear an indoor shoe during the day so that it gives that extra support at home? So we need to look at bespoke footwear as well. And this is where our orthotist comes in. The orthotist is exceptionally good at making bespoke footwear, both stock and bespoke. So they will take a cast of a specific foot and make a last around of that so that the patient actually has a shoe that fits them rather than pushing their foot into a shoe that doesn't fit them. And also we can make specific insoles, total contact inlays that will help distribute the weight when the foot is intact. So we're going to run through a few offloading devices specifically that I use in my trust and in a previous role as well. But you will have different ones in different areas, and do your research, find out what is out there. And if you don't have access to these devices, then approach people in trying to get them ordered, or trialing some and seeing if you get good results with them. Then you can move forward, do some case studies and build some business case towards getting some in stock for yourself to use. So Profo, it provides a 90-degree alignment of the foot and ankle, and it helps to protect the Achilles region and also take the weight off potential heel ulcerations as well. It works well for treating heel ulcerations because it controls the internal and external rotation of the hip, and it provides control of this movement. The foot is not able to rotate medially or laterally. So this is a PODUS boot. I use this boot quite a lot in patients who are on the ward, fairly immobile, quite bedridden. And as you can see, there's a rod on the right-hand side. A rod will pivot either medially or laterally to enable the lower limb to be kept in alignment. And the heel will be completely suspended right through to help to aid foot ulceration on the heel particularly. So forefoot offloading devices and rear foot offloading devices. These speak for themselves. However, what the patient needs to do is take on the forefoot offloading device, take their weight through their mid and rear foot, and on the rear foot offloading device through their forefoot and midfoot. So they're doing like a stamping gait. They're not allowed to put the ulcerated area to the floor. But careful assessment needs to be done with these patients because they probably will need some sort of a walking aid or to look at practicing walking. And sometimes I will involve a physiotherapist in helping the patient realign the way that they're walking. And peg assist is quite useful. This is an insole that comes full with pegs, little hexagonal pegs. And what you can do chair side is take the little pegs out over the ulcerated area. You then lay a reinforced patch on top, and this will offload the pressure immediately. It's quite good at chair side and a quick resolution. You just have to be careful that those insoles don't flatten underweight and given time. So it's about being semi-permanent, looking to a more permanent device later on. The aircast walkers, these are almost gold standard, and they incorporate a rocker sole for maximum offloading. So they will take the foot through the mid-stantive gait quickly and avoid pressure points. They've got air cell lined shells that maximise plantar unloading and regulates shear stress and provide protection and immobilisation. They've also got the valves at the side of the air walkers that will help to stabilise during walking and give an absolute fit. And they help to reduce edema. So here's two examples. We have the full length and the short length air walkers. The problem with these, as you can probably tell, is they're removable. They're only as good as the patient that you fit. So again, it's around, like Joe said, careful assessment. Total contact casting is another gold standard, and the key to all of this, for however it's very time consuming, is that these are non-removable. So the patient can't take them off to drive the car or go to work or do whatever they shouldn't be doing. And there are different casting systems that can be used. The bowler walker on the right hand side is quite a complex thing, needs to be done in the casting room, and this absolutely suspends the foot into mid-air and is good in the management of the sharper foot, as Jill mentioned earlier. So contraindications to offloading that we have as podiatrists to consider is the infection, exudate dressing, so wound management, what's going on underneath these offloading devices that can't be just left. So lymphedema and edema, as we've mentioned, concordance and social care. Making sure that we do a holistic assessment of that patient, look at the gait, the balance. Is it something that they're going to be able to manage with an offloading device for, or will they need, like we mentioned before, some sort of walking aid to help that balance through until things improve? Have they had a previous DVT? And where is the wound? Where is the wound location? It's that we need to be offloading. We need to consider their social circumstances. A lot of the patients we're seeing these days are working patients. They are in the 40s, 50-year-olds with foot ulcerations, amputations, and they still need to work. They still have to earn a living. They're the main breadwinner. So we have to consider patients who we know if they didn't work, they wouldn't earn. So it's about knowing what's out there for them, grants and what they're able to apply for. But looking at, are we going to take away their independence as well if we ask them to not drive? What are their normal activities, their intimacy, their sleep pattern? Are they offended by the smell? Any itching? Are they able to bathe and shower? Can they get the seal type from the GP? And are they worried? A lot of these patients know somebody else in the family or on social media as the first thing they turn to that have had these sort of problems before and that have led to a major limb amputation. So for me, in these sort of patients, it's continuity. It's getting to know your patient and making sure you take that patient on board. Will they come to appointments? They're big commitments. It's usually once a week, if not 2-3 times a week, with the district nurses involved, the practice nurses involved. It's life-changing for a long period of time. As I mentioned right at the beginning of my presentation, they're chronic ulcerations that can lead to being permanent with foot deformity, for example, a Charcot foot. Are they wearing the devices as prescribed? You can generally tell if these patients are looking at the wear and tear of the devices or if they're not wearing them at all. And do they fully understand what would happen if they didn't? We have to look at the psychological impact of these patients because that can lead to the non-concordance, not attending appointments and slipping through the net. So as podiatrists, we're constantly in the back of our mind waking up at 3 o'clock in the morning wondering if Mrs. X or Mr. Y did attend his appointment, and we'll look that up the next day. And we've got this list in our head of these patients that we know are really at risk. So like we talked about before with the risk stratification tool, Joe mentioned the different levels. A patient that's been previously ulcerated has got a high risk of ulceration again, will never be discharged from our service. That's where I see podiatry services being, in that all we will do is look at these high risk patients. We're the specialists in that field to be able to manage these pre-ulcerative, post-ulcerative patients. It's good advice to the patients as well, giving them support, giving them education on avoiding walking barefoot, inspecting their feet daily. If they can't do it, get a relative to do it. Use a mirror to get down to look underneath the foot if they can't reach. Properly fitting footwear, as we've mentioned previously. Any signs and symptoms, if they're feeling unwell, any signs of infection, to ring the 311s and get some advice. Knowing where to refer, when to refer as well. Where's their nearest health centre? Where's their nearest A&E? Everybody needs to know that in case of emergency. So it's looking at giving them a full package of care forevermore. So really what we as podiatrists do, we're a very small profession. I suppose we're quite elite really, but what we go around doing, either consciously or subconsciously, is educating other healthcares. We do that one-to-one on a daily basis, round a bedside, or we'll do it in group training sessions, or areas like we're doing now on social media. We're doing conferences about raising awareness of our clinical practice. We want to encourage the MDT approach. It's hard work, but it's rewarding. I spend a lot of my time on mobile phone, arranging times to meet at patients' houses with district nurses, and it's the best way to learn. We all learn from each other. It's about educating those patients that are there, as we've said before, they're pinnacle to the care. Without the patients and the carers and the family, we would have absolutely gone under during COVID. It's made me realise how important they are to overcoming foot ulceration. So don't forget 3 Ps. It's not location, 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 like we all see on TV. It's prevention, prevention, prevention. Early detection is key to preserve and to protect. We're also looking for a call for action. Joe and I are both coalition members of the Legs Matter group. We're a small group that are nationwide. We do the best work we can do, and we'd like you all to get involved. So please join us, because together we can all make a difference. legsmatter.org/get involved. So I'd like to hand you over now to Alec, who's going to take any questions from the floor for Joe and I. Thank you.
Thank you, Jill, and thank you, Joanne. That was a fantastic presentation. I learned a lot. One of the things that just kept ringing through my mind, actually, talking with this being a sort of a Legs Matter presentation with you as podiatrists, is that, you know, sometimes if you come from the background that I come from, which is sort of wound care, we often will sort of overlook the foot element of the leg, because you're sort of thinking about, you know, the calf area really from a leg ulcer point of view. So it was really, really interesting. There's just something I want to say, actually, which is I've been doing some calculations, Joanne. You said at the beginning that diabetes costs £315 per second, or 10 billion per year. And sometimes it's really hard to try and put into sort of figures, or to try and get people to understand what 10 billion is. You can say 10 billion to me, it doesn't mean anything, because it's such a ridiculous number that it just doesn't matter, does it? It's, you know, when you hear about sort of, you know, PPE requests and things like this through COVID, this costs 5 billion, 3 billion, whatever those numbers are. So I just worked it out, because you said, I don't know if anyone's got time to work it out. So I did some workings out, right? So £315 per second, you were talking for exactly 2 minutes before you said that, which is £37,000, £37,800 in 2 minutes. So that's higher than most nursing salaries, is fair to say, which is a scandal in itself, but that's a different topic. So it's £37,500 over 2 minutes. To put into context, that works out as £1.1 million an hour for diabetes, 1.1 million. And I think people can probably understand 1.1 million a bit better per hour rather than 10 billion per year, because 10 billion is so far removed from what we all understand from a, or from maybe there's somebody watching in the audience that has 10 billion pounds and thinks, yeah, I can do that. But to put that into my final point, my final stat, this is just a random stat. My final stat is that 10 billion pounds a year. I live in Cardiff. There's about 360,000 people who live in Cardiff, and 10 billion a year would employ every single person in Cardiff to be a nurse for a year. So that's bonkers, isn't it?
Crazy, crazy.
Can I give you two more stats, Alec?
Yeah, of course.
This will test your maths. Somebody across the world is diagnosed with diabetes every 2 seconds.
Somebody across the world. So what are we doing? We're going. So we need to. I'll come back to this by the end. Okay. I'll have figured it out. But basically,
and then the other stat is that every 30 seconds, across the world, somebody loses part of their foot to diabetes foot disease.
Oh wow! Well, somebody who's watching will be able to tell us what the global conversion is.
I just think that impact is huge.
60 odd million people in England where these stats come from, and there's now 7 billion people in the world. So what's that? We're timesing it by 100 or something, or timesing it by 10. So we just need to figure that out. But listen, we've got about 10 minutes, and there's loads and loads and loads of questions that have come through. So I'm not going to waste any more time with my stats. And there's a couple of things about offloading devices that I want to talk to you about, Jill. But I'll do that offline once we finish. Just for the audience watching, we know that you've sent in lots and lots of questions. We're not going to be able to get through every one of them this evening, but we will get back to them at some point. So what we'll do is a copy of this presentation along with the video will be available on our website from tomorrow. The video will be available on our website on our Facebook page pretty much immediately after we finish. But in a week or so, what we'll do is we'll have created a document listing all of the questions that you've asked this evening, and we'll come back with answers, and we'll put that up as a PDF next to the video of the presentation and the presentation itself. So without further ado, let's get some questions, and we do have time just for a few more to come through. But the first question is, I'm not sure who this is from, but it is, can a patient lower their risk level of ulceration? So I'm going to hand that over to you, Joe. We're going to try and do a bit of a quick fire with some of these. So can a patient lower their risk level of ulceration?
Yes, well, there's two answers to that question. If they've developed a foot ulcer, then the answer is they will always remain high risk. So there will always be a high risk patient. So you can't go from high risk to moderate risk if you've developed a foot ulcer attached to diabetes foot disease. If you are of moderate risk, you can lower your risk status. If you offload the foot, for example, if you had a callus and you managed to take away the callus by correct offloading, you could go down to a low risk. If you had a corn, again, another skin condition, if you, for example, if you had fungal nails and you got rid of the fungus in your nails, that would be a risk factor. So again, you can reduce the risk that way. But once you've had tissue breakdown or amputation or an ulcer, then you'll always remain high risk. But for those people without ulceration, you can bring the risk status down.
Okay, brilliant. Thank you. Hopefully that answers the question. Jill, I'm going to go over to you next because this is about devices. So how many pairs of bespoke orthotic shoes and insoles can a patient expect to have a year?
Well, that does vary, Alec, I think, from trust to trust. From my experience, they were entitled to 2 pairs a year. However, you do get some of the patients that come in who are very, very hard on their feet. So the working man who's in steel toe cat boots, for instance, and has to have those bespokely made, they can be bespokely made, and they're very heavy on their feet, either occupation or their weight. We always used to say to patients, don't just think because you can't have another pair of shoes that you would wear a very worn pair of shoes and make your feet worse by having them worn out and still wearing them, because a neuropathic patient would carry on, say, with a worn pair of shoes and not realize that they were beyond their function. So really, I'm sure any orthotist would inspect a shoe if it was very worn to look at replacement. but they are very expensive. They are very up to £400–500 a pair, and that's minus any special adaptations that are put on. So
they can change the insoles, can't they, Jill? So
yeah,
and they can the insoles change and not the shoe. It kind of
yeah. I mean, we tend in podiatry to be quite specific with our insoles, so we can remove the insoles that the orthotist will make, but also it's up to a patient to be very careful looking at the sole of a shoe, that they don't let the sole and the heel wear right down, that it's beyond repair, that they get those recobbled or resoled and healed at an early stage before it means a actual new pair of shoes.
Okay, well, I think that's. I think the key there is that it varies from trust to trust, and is it about also just making sure that the patient understands when they need new ones? Well, the patient, I guess, will be aware. I know when I need a new pair of slippers. They stop being quite so tight, and they get some holes in them after a couple of years. Will the patient be aware that actually this isn't working for me now? I need a new set.
And I think as well, it's up to the podiatry team, when they go to appointments, don't just look at the feet, look at the shoes as well, inspect the shoes, look inside the shoes, like I said, to say, are they getting worn, and I usually ask the patient to contact the orthotist. I get them to take some responsibility in contacting the department, but I will prompt them and make a note in my notes that I've said that to the patient, that really they should be contacting the orthotist for a review of the footwear.
Okay,
it goes back to that 5-point assessment, doesn't it? That was that footwear at the end. So it's well, you can do that assessment almost every time, whether you're whatever sort of healthcare professional you are. If you just in your head have that 5 points, shape, skin, circulation, sensation, and footwear. What's going on every time? Wear your shoes. What have you got on feet? What are you wearing indoors? Get rid of those slippers. They're going to make you fall over. Buy indoor shoes. So just checking, I think using that 5-point assessment is quite useful.
Okay, brilliant. I'm going to sort of just ask for short and snappy answers to the next few, so that we can try and get through as many questions as we possibly can, because they're still coming through, believe it or not, and we'll be here. I've got a bolognese on the stove, so I've got to go. So the next question is, if a patient refuses to change their footwear to prevent pressure to the skin, what can I do? Joanne, would you like to take that?
Educate. Okay. And you can also use motivational interviewing. So sort of tools to motivate patients to understand and maybe to see the benefits of having good footwear. Think mobility. But education is.
But you're specifically talking about education for educating the patient.
And the carers, the family, encouragement. Yes, I would educate them, what are the reasons behind it? Why don't they want to change their shoes? If they've got neuropathy and they're saying, well, those ones aren't comfy, it's difficult because they can't always feel so much. So maybe it's more about the fact that they don't like the look of it, or it feels too stiff. Encouragement,
Okay, thank you for that. The next question is, when would you refer to tissue viability or a GP or even vascular services? I'll hand this over to you, Jill.
I think all the time. I involve all those disciplines all the time. If I'm very worried about a patient, then obviously to the vascular services. But generally, my work with tissue viability nurses is interlinked. That's the key. We are as one. A wealth of knowledge in all camps, and the GP. Maybe for antibiotics sometimes, and a little bit of a support if there's some sort of social aspect, but more than often than not, it's nursing.
Okay, brilliant. So the next question is, if my service does not, I'm going to go back to you for this one, Jill, I think, just because you were talking about these things. If my service does not offer total contact casting, what should I offer next to offload the foot if they have a foot ulcer?
I think there are lots of things chairside we can do. I mean, the Pegasus insole was the one that I just demonstrated, but I think we've got access to semi-compressed felt and adhesive padding, which I'm not happy at all long-term about that being onto the skin, because it can mean the tissue viability becomes very poor long-term and the skin is already very friable. However, you can reverse that over and stick padding onto the insole of their shoe and make that some sort of a deflective pad.
Okay.
For the time being.
The removable device, Jill, the removable device, you know, the air cast boot. That would be another option, wouldn't it? For if you didn't have a total contact cast, you might even find that in your stock cupboards. The air cast
can I ask a question? I genuinely know the answer to this, so I'm sorry if it sounds a bit daft, but can you get total contact casting? Can you get the full cast outside of a hospital setting? Is it? I'd imagine, isn't it just purely in hospitals or orthopedic centres where they have casting centres?
No, I mean, majority of it is, and you have to build really good relationships with your plaster technicians, but there are casting systems that podiatrists can do chairside. So we can take that into community and even into the patient's home. So again, it's about finding out what's available out there for you and doing your research, but it is time consuming. It's time consuming getting pathways together, information leaflets, but I think it's very worthwhile doing, but picking your patients very carefully, because there's lots of contraindications.
Yeah, I broke my leg in 2 places, not last year, the year before. It was in September, and I was in a total contact cast, and when they took it off me and put me into an air cast, after a number of weeks or something, there was a chap in the bed next to me having his total cast removed, and he had a diabetic foot ulcer, and he had been in this total cast for 3 years, coming in every month and having it changed for 3 years. And it was interesting because I'd never come across, I just didn't know, despite being in this industry for a long time, that total contact casting for prolonged periods of time was a treatment for diabetic feet. But he was obviously going into the hospital to have it done. So, yeah, I mean, I've learned a lot this evening, and I hope that everybody who's joined us has learned a lot also. We've gone over time slightly. That potentially could be because I ask too many questions myself. So I do apologise to everybody watching, and I apologise to you and Jill, Jill and Joanne, for missing a few of the questions from the audience to answer my own. But I'm just genuinely interested in this as a subject. I found it absolutely fascinating, and I know, because I've watched the comments come through, that the audience is equally as fascinated. So please do, if you're still with us, keep an eye on our website, because we'll be putting a copy of this video up online along with the presentation. And as I said, that should be available tomorrow, but within a week or so, or in a couple of weeks potentially, keep an eye out. We'll have a full list of all of the questions that have been asked with answers to them. I'd like to thank again Legs Matter, because I think it's a fantastic organization, and it's basically a fantastic initiative to really get the UK talking about legs and feet. I know that when it first started, seeing the sort of stuff that getting industry involved and doing things like people standing in supermarkets and talking about legs and feet. I mean, it's fantastic, and so I really love that. So I'd like to thank our friends there. I'd like to thank my team who are working this evening. Most of all, I'd like to thank every single one of you who have joined us this evening to watch. We'll be back on Thursday, actually, over on our Urology and Continence Care Today page, should you be interested. We've got a continence event going on there via Facebook, so please do come and join us. And last but not least, we have Wound Care Today taking place on the 28th and 29th of March in Milton Keynes. Spaces are free. We've got a few left, so if you haven't booked to attend, please do attend. We've got diabetes content and diabetic foot content on the program, along with companies, and you can come and see some of the products that have been mentioned tonight by Jill. Jill, Joanne, thank you very much for this evening. I could sit here for the rest of the evening telling you how much I enjoyed it, but I'm not going to, because I'm sure that you're desperate to go and have a glass of wine and some dinner. So I will leave it at that. Thank you, everyone, and we look forward to seeing you again soon. Good night.
Yeah.
Thank you.